Hey everyone, this is Sadie Agurkis, Education and Training Manager here at the Northwest Regional Primary Care Association. Just wanted to say thank you so much for joining us today. We appreciate it. It's a super sunny day here in Seattle, so I don't know about you all, but thank you for joining during your lunch hour on this day. This is our fourth session in our Chronic Disease Prevention and Self-Management year-long webinar series. We're really excited about today's panel. This session is called Care Coordination, the Role of the Clinician. And we have on the phone with us two folks from our office, Seth Doyle. Hi, Seth.
Hello.
And he's going to be moderating this session today. And we also have Chris Spencer. He's our distance learning specialist. Hi, Chris.
Hey there.
So we're all here with you today. And Seth is actually going to introduce our speakers for today's session. So I'm going to hand it over to him.
Great. Thank you, Sadie, and good afternoon, everyone. I'd also like to extend the thanks to you all for joining us for the webinar series, and for today's webinar that we have. We've got a great team from Virginia Garcia Memorial Health Center in Oregon who will talk about the work that they are engaged in around team-based care and how they're able to coordinate care in their model. So I'm going to introduce each of the presenters for today's webinar, and then we'll turn it over to our colleagues at Virginia Garcia for their presentation. So with us today we have Lydia Jackson. Lydia is a physician assistant at Virginia Garcia Health Center. She graduated from Duke University School of Physician Assistant Studies in 2008, and she began working at Virginia Garcia Health Center in that same year. In addition, in 2013, she joined the faculty at Pacific University School of Physician Assistant Studies. So we're glad to have Lydia on with us this afternoon. We also have Dana Kuhn. Dana Kuhn is a family medicine physician who went to Mount Sinai for her residency and George Washington University for medical and graduate school. Her interests include medical education, underserved medicine, global health, and women's health. And she writes that team-based care has changed her professional life and reduced her stress level immensely, which I imagine many folks can appreciate that who work in a health center environment and all of the stress and pressure around that. So thank you, Dr. Kuhn, for joining us this afternoon. We also have Samantha Flores. Samantha Flores is a clinical pharmacist with Virginia Garcia Health Center. She received her Doctor of Pharmacy from Pacific University in Oregon. She then went on to complete a PGY1 community pharmacy residency at Virginia Garcia Health Center, and then a PGY2 ambulatory care residency at Kaiser Permanente in Colorado. Finally, we have Sarah Phillips with us as well. Sarah Phillips received her Bachelor of Science in Nursing from the University of Portland in Oregon. She has always been interested in primary care for its opportunities in education, care coordination, and teamwork. So as you all can see, we have a great team from Virginia Garcia today, representing diverse backgrounds and professions. And so we're really excited to have them be able to share the work that they do in a team-based model and how that relates to coordinating care for patients and really helping to address chronic disease management and improve health outcomes. So with that, I will turn it over to Lydia, and thank you again for joining us this afternoon.
Actually, Lydia, before you start, let me just do a couple housekeeping announcements that I forgot to do earlier that will make your session much smoother. Just to let everyone know, if you have questions, just go ahead and write them right in the chat box on the right hand of your screen. That way, Lydia and her team can see the questions, and Seth is going to help moderate those questions at the end. So if they don't get to them right away, don't worry. They're going to be answering questions more towards the end, just in case they already covered those topics. And also, this webinar will be recorded. It's being recorded now, and we do encourage you to share it with your care team, to watch it together, watch it separately, or just so you can learn from what Virginia Garcia is doing together. So please feel free to share that with your team. And one last reminder is that there's an evaluation at the end of this session. We'd love for you to fill it out. It helps us so much in preparing the future webinars. So thank you, and take it away, Lydia.
Thank you. All right. So I'm going to click through here. So today I'm here with my team. We're going to be doing our best to help everyone listening to the webinar better understand what the medical home model is and why it's so effective at helping us as providers function at the top of our licenses while providing the optimum care to our patients. We hope that we're going to demonstrate some of the nuances of interdisciplinary care through a few of our primary care cases. Our presenters today include myself, I'm a PA. We have an MD, a PharmD, and an RN here. So we're going to be happy, and we'll be happy to answer any of your questions at the end of the presentation. So like Seth said, I'm a PA. I've been working here since 2008, and I have had the experience of working here prior to working in team-based care and then making the transition to team-based care. And I think probably one of my favorite things about working on a team is being in that team setting and working with other people to better manage our patients. And so my successes are also our team successes, and we enjoy that. It makes coming to work enjoyable each day. I'm going to pass it off to a couple of my other presenters to share, just introduce themselves, and then we'll get started.
My name's Sarah. I'm the nurse on the team, and I've been working at Virginia Garcia Clinic for 4 years, so only known the team-based model, but love it. Always kind of been a team player, and I appreciate really getting to know the panel and kind of sharing the perspective with all the different kind of team members on the team to kind of come together to make the best plan of care for each individual patient.
So my name's Sam. I'm the pharmacist on the team, and I've liked working on a team mostly because as a pharmacist, most people think of me in a pharmacy, and I don't work in that setting at all. And it's able to give our patients a little bit better care, and I get to affect not just the patients I see with my small panel, but all the patients in the clinic, because we help with multiple questions, and the RNs, the MAs, and all the providers.
Hi, I'm Dr. Dana Kuhn. I just started working here in August, and I came from a non-team-based care clinic, and this is life-changing here. It's definitely reduced the administrative burden, and I really like, I feel like the patients get better care, and it makes the entire clinic feel like a smaller, warmer place to work.
Okay, so that's where we're going to try to get you guys to understand with our presentation today. So our objective today is first to relate the need for primary care model change. Second, to understand what it means to provide team-based care, the structure of the care and the team players and what their job roles are, and then to describe the benefits of this model. So I'm going to start you guys, let's see. I'm going to tell you guys a little bit about Virginia Garcia. Virginia Garcia Memorial Health Center is a FQHC comprised of 5 clinics that serve the underserved populations of Washington and Yamhill counties in Oregon. 29% of our patients are uninsured, 56% are insured with OHP and Medicaid, 5% are insured by Medicare, and 10% have private health insurance. 16% of our patients are migrant or seasonal farm workers, so that's one of our aims and our mission is to take care of that population. So I'm going to start you guys off with a little story. I told you that I worked here. I've been working here since 2008. I was a new graduate from PA school at that time. When I started working in the clinic, we were still working with paper charts in our traditional primary care model, the patient-provider paradigm. I went to work as a new grad, and I had a desk in a large room with all the other providers. I really liked the setup. There was a great conversation at lunch, and there's lots of support when I had questions. I thought, wow, we really have it great here. In the end of 2008, our administration approached us to say that we're going to do something called Primary Care Renewal, or PCR, which would help transform all of our sites to the medical home model. Being a new grad, I thought, maybe I should know what they're talking about, but I really don't, and hopefully I can figure it out. In the beginning of 2009, I was given a red index card that had a list of people on it. There was 2 providers, a nurse assistant who are now going to call our patient care coordinator. We had the woman's name who did our tracking for us. She was now going to be our team assistant. There was 2 MAs on it and 2 women from the front desk. Also listed on the card was the location of our new office. In the next 2 weeks, we had 2 more meetings describing what PCR meant, something along the lines of you'll be seeing patients every 20 minutes, but now you're going to work on a team that will support you. The theory seemed sound, but I was still trying to work out how it was going to feel different for me as a provider. 2 weeks later, we had our first team meeting. I have that in quotes because it just consisted of us packing up all of our lives into a small filing cabinet and chaotically pushing them all over the clinic till we found our new offices and chose our desks. An hour later, we're all sitting in a room looking around, smiling at the 6 new faces on our team, and my MA came in to tell me that I had a patient waiting. It was go time. It was team-based care. The change was really hard, and it didn't happen overnight. However, with time, I came to understand how to work on my new team, and it's really apparent to me now how much each of them has come to support me in what I do, make me a better provider, and ultimately offer our patients much better care than I was able to on my own prior to team-based care. Today, I can honestly say that at this point in my career, I would never turn back. The impetus for our clinic's change in 2009 has not changed today. In the U.S., we're faced with a supply and demand problem when it comes to delivering primary care. There's an excess number of patients in the U.S. that are underserved when it comes to health care. The U.S. Census Bureau has reported that 50.7 million Americans, 16.7% of the population, did not have health insurance in 2009. In 2010, the rate of uninsured peaked at 18.2%. It's been shown that patients that lack access to basic health care, including preventative medicine, are more at risk for chronic disease and will have poor health outcomes. In 2014, the ACA policies were put into place allowing millions to be insured, dropping the rate of uninsured to 8.8%, which is a very positive shift in health care for Americans overall, but not solve the demand problem for the federally qualified health centers. If anything, community clinics in health profession shortage areas and medically underserved areas felt the demand for access to visits with medical providers increase. Another increase in demand is the growing population of our patients that are older than 65 years old, which is projected to double by 2030. To accentuate the issue of the excess demand, we have a supply deficit of providers to care for all the patients in need of care. There are 5 circumstances in primary care that are driving the need for change in the model in which we provide care. The first is that we have a large shortage in PCPs. In 2009, the Institute of Medicine estimated that the U.S. needed 16,000 more primary care providers to meet the need, with projections of need to be greater than 100,000 providers in 2030. We also have a compensation issue. Insurance compensation currently favors procedures and technical medicine, not time spent with patients, time spent coordinating care or preventative medicine. This directly affects the salaries of those practicing in primary care. Family MDs make about 55% of what specialty MDs make. The wage gap is smaller among primary care PAs and NPs and their counterparts, but it's still present. There's also an issue with the number of people graduating from medical school. The number of medical residency slots is controlled by Medicare funding and policy. That has not changed for many years. This is a policy that hasn't changed for many years. The number of residency openings does not meet the demand of graduating med students and limits the number of MDs completing a residency in a time when the population that needs care continues to grow. In PA and NP education, the bottleneck is increasing class sizes and graduating more practitioners is a lack of preceptors and rotation sites. With the lack of providers, we also have an increase in patients with chronic disease. Over 10 years ago, the CDC estimated that there is greater than 130 million Americans living with at least one chronic disease, which encompasses 7 of the top 10 leading causes of death. Managing these diseases require a complex set of services that fall on the PCP to coordinate. There's also a current reimbursement system issue that we're reimbursing more face-to-face office visits with a doctor or mid-level provider. This leads to overbooked schedules, hurried visits, and patients defaulting to the emergency room for primary care services. All these factors are leading to an increase in PCP shortage because there's less MDs, PAs, and NPs deciding to come into primary care, as well as a higher rate of turnover and burnout. The concept of the medical home was first introduced by the American Academy of Pediatrics in 1967 as a place for all providers to access the medical record of a child with special needs. The idea of coordinating care to favor the patient and family's needs evolved from there and cultivated a partnership between the patient, family, and primary provider in cooperation with specialists and support from the community. The patient and family became the focal point of this model, and their medical home was built around the center. In 1992, the AA put out a statement about patient-centered care in a medical home that was revised in 2002. The statement gave an explanation of the medical home's crucial characteristics. These guidelines stress the care under the medical home model must be accessible, family-centered, continuous, comprehensive, coordinated, compassionate, and culturally effective. In 2007, the AAPA joined the American Academy of Family Physicians, the American College of Physicians, and the American Osteopathic Association to form the joint principles of the patient-centered medical home. The joint principles of the patient-centered medical home state that the care should be based on the physician-led practice. Patients should have access to their own personal physician who leads the care team within a medical practice. It should be whole person oriented. The care team provides comprehensive care, including acute care, chronic care, preventive medicine services, and end-of-life care at all stages of life that's focused on the patient and their unique set of needs. It's integrated and coordinated. Practices take steps to ensure that patients receive the care and services they need from the medical neighborhood in a culturally and linguistically appropriate manner. There's a focus on quality and safety. Practices use the quality improvement process and evidence-based medicine to continually improve patient outcomes. And there's a focus on access. So practices commit to enhancing patients' access to care. The following are two definitions that have been put out for the medical home model. The AAFP says it's a model of care that aims to transform the delivery of comprehensive primary care to children, adolescents, and adults. This practice seeks to improve quality, effectiveness, and efficiency of care they deliver while responding to each patient's unique needs and preferences. And the Institute of Medicine says further, providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring the patient values guide these clinical decisions. So now we're going to back up a little bit and address Virginia Garcia's path to making this large system change. Realizing the need for change back in 2006, Care Oregon, which is one of the managed care organizations in the state, traveled to Anchorage, Alaska with representatives from 5 of the clinics in the Portland area to visit the South Central Foundation. This is an Alaska Native-owned nonprofit healthcare system that had changed their model of care in 1999 to structure it around patient-centered and population-focused provider teams. The teams were co-located to improve collaboration, and it was emphasized that the quantity of visits was no longer the focus of care, but rather getting the best healthcare outcome for their patient panels. Upon returning from Alaska, the group had a powerful and attainable vision that took them from should we do it to how can we not do it. Care Oregon came up with the money to fund the project that they would call Primary Care Renewal, or PCR. Their 5 goals of PCR were team-based care, barrier-free access, integrated behavioral health, proactive panel management, and customer-driven care. In 2007, 5 teams were formed, one at each of the 5 pilot clinics. These teams practice team-based care and develop workflows for the clinics. They also met on a regular basis to discuss best practices and challenges. In 2008 and 2009, PCR, or Primary Care Renewal, spread from the 5 clinics to 26 clinics that collectively had formed greater than 80 patient care teams. In 2009, Care Oregon and the participating clinics co-designed a quality-based payment model which rewarded improvement in clinical measures such as PAP rates and decreasing A1Cs monetarily. In 2010, these clinics were realizing a decreased rate in hospitalization and emergency room visits. Care management, which involved a more complex utilization of the nurses to help affect behavioral changes, also started in 2010. In 2013, VG, as well as a few other clinics, took the next step in change and implemented the alternative payment method, where instead of getting paid for face-to-face visits, the clinic is paid a lump sum monthly, which is a capitated fee for all the patients that we take care of as a clinic, whether or not they come in that month or not. This has allowed for a new vision of care delivery that could come from the person on the team that is most suited to interact with the patient. Virginia Garcia went into this transition with a quadruple aim: to have happier patients, to have healthier patients, to lower overall costs, and to have happier staff working at the top of their license. And by sticking to the main pillars of the program, patient-centered care, team-based care, same-day access, proactive panel management or population management, and behavioral health integration, they expected they could accomplish their quadruple aim. The medical home model is a patient-centered model where the patient's the driver of their healthcare needs. There's a team approach to taking care of the patient rather than the provider being the patient's sole caretaker. At Virginia Garcia, each patient has one patient care team that consists of a provider, a patient care coordinator, a nurse, a team assistant, a medical assistant, and a new position on our team is called the clinical team lead. The care we provide is primarily directed by the team member who's in charge of seeing the patient in the clinic, contacting the patient in between visits to follow up on all their healthcare needs, and helps the patient develop a care plan that incorporates the best use of the resources the clinic has to offer. There are other resources housed within the clinic that the patient will have immediate access to if needed. These are behavioral health and clinical pharmacy. Each of Virginia Garcia's clinics has their own pharmacy as well that can access their providers in a timely fashion should any medications questions arise, and help our patients get the best prices for their medications. There are a multitude of other resources that the organization has to offer our patients as well. The medical home allows for an individualized care plan for each patient, involving all the key players needed to optimally improve their health. This model offers the patients the opportunity to be seen by a high-functioning clinical care team. The medical home looks slightly different in clinics across the state and country, but the concept will be similar. Everyone on the team is working towards the same goals to provide the optimal care to the patient coming from the care member who can most effectively deliver it. I'm going to pass this over to Sarah.
All right, thank you. So I'm going to talk a little bit about each role and how it works. So here at Virginia Garcia, VG, our team consists of typically a provider, PCP, 2 to 4 per team. Then we have our patient care coordinator, which we'll refer to as a PCC. There's one of those. We have one team assistant as well, a nurse, and it depends on the panel, but 1 to 2. And then a medical assistant is 1 per provider. And then our new role, the clinical team lead, or CTL, 1 per team. And then we have front desk staff, behavioral or mental health, 1 to 3 per clinic that we all share, a social work community outreach that we also share, 1 to 2 per clinic, and then clinical pharmacy, there's 1 team per clinic. So the team cares for a panel of patients, which is the sum of the patients on each of its providers' individual panels. In our clinic, there are 5 teams, so each team takes care of only 1/5 of the patients that come into the clinic, allowing for a more intimate relationship with them and better knowledge of that particular patient's barriers and needs. Over the next few slides, we'll delve a little bit deeper into each team member's role. So starting off with the PCC, our patient care coordinator. Our PCC is the backbone of the team. She's a point person for patients to call and reach us. The patients or our patients will typically know their PCC's name or have his or her direct phone number to call the clinic with any questions or issues. This helps the patients access their team with a much greater ease and decreases the risk of their calls being put on hold for too long or being dropped. The PCC listens to issues and then directs them to the appropriate party. Our PCC also relays information from the providers to the team, to the patients. So, for example, normal results, education, and follow-up plans. So, and then the next thing PCC does is works with the nurse and the TA on proactive panel management, which is a team-initiated way of assessing a population of patients with a chronic disease and reaching out to them to address gaps in their care, rather than waiting for the patients to come in for their visits. Then, let's see, she also contacts patients who have been in the emergency room in the past couple of days to get them back into primary care for follow-up. This really helps reduce patients visiting the emergency room for multiple times for the same issue. Next, we have our team assistant, TA. TA handles more of the administrative tasks on the team. In our case, he makes and tracks referrals, tracks patients when they need follow-up, also does preventative medicine and chronic disease outreach, such as tracking normal and abnormal PAPs and then reminding patients to follow up for those. Helps identify if they qualify for Medicaid or OHP, and helps the patient navigate that process of signing up. And a new addition is we're trying to get more patients on our online messaging system called MyChart, so really helps identify the patients who would be good candidates for MyChart. Next up, we have the nurse. That's me. What I do, I work at the top of my license, and so I have some clinic protocols that allow me to do so. It allows me to take care of patients with minor urgent complaints in the clinic, so UTIs, ear infections, sore throat, things like that. Also care for patients over the phone. I provide a lot of education doing that. We also run the anticoagulation clinic for all our patients on warfarin who might need dose adjustments. A few years back, we were educated on how to work with patients on a more regular basis to help them make plans for change and coach them through these changes. We provide a lot of patient education, such as reproductive information, contraceptions over the phone, and then also help with care coordination for patients in nursing homes or in transitions of care between the hospital or rehab center, and then get them back into the clinic. All right. Next to medical assistant. Medical assistants are assigned to their own provider, which helps the pair develop a stronger and more efficient workflow, as well as add to continuity of care for the patient. Along with their main functions of rooming patients, collecting back office labs, and screening patients for tobacco, alcohol, drug use, and depression, they manage the flow of the office visits during the day. They scrub the patient's chart, looking for any gaps in care that might need to be filled, and assess the patient's preventative and chronic illness care needs. There is then a protected 20 minutes at the start of each day for mainly the provider and the medical assistants to huddle and review the plan for each visit. The team will be involved in these huddles as necessary. Lastly, when they are not on the floor with the provider, they are handling their float visits for patients with care needs that fall under the scope of practice, such as vaccines. All right. Next is our CTL, the new role on our team, clinical team lead. This person is a member of our clinical management team and functions as a staff manager at the team level. She helps manage schedule changes, find coverage for clinic workflows. She also sends out a daily bulletin with staffing and clinical updates. She's in charge of reviewing the team's panel reports and deciding on metrics that the team can work on. She then completes staff performance evaluations for everyone except for the providers on the team. Now I'm going to pass it off to our doctor on the team, Dr. Dana Kuhn.
Hello. So I'm going to talk about the role of the primary care provider. So on every team, there's a certain amount of PCPs. Our team, for example, we have 2 MDs and we have Lydia, a PA. Other teams in our clinic have MDs, MPs. Another clinic site has a naturopath, so it varies per team. And so depending on how many of the primary care providers, if they're full-time, part-time, this will impact the total number of patients that the team carries. So this is the sum of the panel that the providers have. All of our patients make up the sum. And so during the day, I'm seeing patients in the clinic, and then I'm using my great team throughout the visits and afterwards and during my admin time, and they're helping me. So for example, this morning when I saw patients, I had my TA come in afterwards to sign a patient up for my chart. I asked Lydia a second opinion because she was right there in my team room. I could pull in Sam for a pharmacy question about drug interactions, and then I can use my medical assistant to help me with the paperwork and the patient care coordinator, and to also help me fill out a prior authorization and just get some follow-up with patients. So it's really, we all work together as a team throughout the day. Oh, okay. So this is our picture of all the team members. So what I also really love about our team approach that a lot of clinics don't have, we have behavioral health. We have so when I'm seeing a patient, and for example, I have a patient with poorly controlled diabetes, and they're interested in working on behavior change, I can pull in my behavioral health clinician, and she can come in and work with them to improve their health outcomes. And so, for example, she works with coping skills, and she fosters motivation so they can make lifestyle changes, such as changes in diet, increasing in exercise, or just being more compliant with their medications on a day-to-day basis. Also, you know, we have a lot of patients with depression and anxiety, insomnia, and these are commonly comorbid with chronic disease. So if I have a patient who's depressed and I need someone to see them that day, I can pull in behavioral health clinician, and we do warm handoffs, and this means that during my visit I can pull in someone to come in and help me out with and offer small interventions, and they develop a rapport with the patient, and this has been shown to improve patient follow-up rates with the behaviorist in the future. So it's really great, and they've had some successful smoking cessation groups in the past, and they've helped patients with pain evaluations. Another thing that's really great is if, let's say, I have a patient in acute crisis, they're suicidal, I can pull them in and they can help me work with the patient at the time of the visit. We also have, in the mental health spectrum, we have a mental health therapist who can provide long-term therapy, depending on the insurance, with mental health issues, and they can come in for counseling visits with the therapist. And then we have a mental health nurse practitioner, and so she can see our patients for medication recommendations and for lab monitoring. So for my patients with schizophrenia and complicated mental health issues, she can help me, give me recommendations. And finally, we have a mental health clinical pharmacist who further helps with the medications and the lab monitoring and can meet with the patients to discuss the benefits and the side effects of their medication.
All right, so this is Sam, the clinical pharmacist, once again. The next person on the team we're going to talk about is clinical pharmacy. We're available for all the teams. Usually, most of our clinics have 1 to 2 of us, and we sit on the team, so we're co-located and can answer questions of the providers as they arise, or answer questions for our nurses as they're working on their anti-coag protocols. If anything kind of falls out of that, usually their next person is me. Before going to a provider for further help. We're available for help with complicated diabetics and hypertensive patients. We hold our own little smaller panels to manage those, and we start, stop, or adjust any medications based on our collaborative agreements with our providers. We're also available for help with patients who are non-adherent, don't understand their medication regimens, have a complicated medication regimen and need some adjustments to make it a little simpler. And then we work pretty closely with our behavioral health providers, sometimes even having back-to-back visits. So mental health can help with, behavioral health can help with those behavior changes, and then I can kind of go in and help make some small adjustments to their medications as they make those behavior changes so that they have less side effects of their, in particular with diabetes, less hypoglycemia, which is a big issue sometimes with patients making changes. The other thing we also help with are transitions of care. So if patients are transitioning from a SNF or from a hospital, sometimes you can have back-to-back visits with a provider. So we'll go in, see the patient first, kind of clean up their med list, figure out what happened while they were in the hospital and what they were discharged on, and then the provider can go in afterwards. And it makes the visit a lot smoother for the provider and also for the patient. Then we have community outreach workers, which are extremely helpful to patients as they can help patients get access to resources like food banks, transportation or clothing, sometimes even housing, depending on what the situation is. We also have a team that goes out to our migrant farm camps. It's a van that goes out twice a week to different camps in the area in the summer months where most of our patients out there can't actually get to clinic, so this opens access to them. It also helps because it's also really good for our providers and our MAs that go out because it's a really strong experience and kind of reinforces the fact that why we're doing what we're doing here at Virginia Garcia. We also have diabetes education. So this is run by our nutritionist and a pharmacist that's a CDE, and they have 5 different classes at our main clinics, ranging from beginning diabetes, and then they go all the way to complex insulins. If the classes are available in Spanish and English, but let's say patients are illiterate or they may not do well in a class setting, we also have one-on-one visits for those patients. So that we kind of can help everybody as much as possible that best suits them. Our other resources, and these may not always be at our home location, but our patients can see them at other locations as well. We have an acupuncturist, a naturopath. We have DO residents here who provide osteopathic manipulation therapy. We have like we said, we have a specific transitions of care team that sees patients once a week, and they consist of an internist, a PA, a pharmacist, behavioral health provider, social worker, a physical therapist, or an occupational therapist, and then PA students that round with them as well. We do group visits, which is like A Tu Salud, which is mostly for diabetic patients, and then we have centering pregnancy, which is at our women's clinic, and our classes for our pregnant females. We have school-based health centers that are located actually at our schools and local school districts, and this helps students not have to leave class for so long, and they have easier access to healthcare right at their school without having to leave. We have dental clinics as well at our 5 main locations, and then we have a wellness center that offers cooking classes, Tai Chi, Zumba, and yoga classes, which all our patients can go to, doesn't matter what clinic they're located at. So a little bit about comparing our model to the standard model. So you can see prior to a visit with the standard model, the MA would have scrubbed the chart, but there may not have been enough time for the provider to do so. So a lot of what's going on is kind of unplanned. During the visit, the MA rooms the patient, draws back office labs, and then they wait for the provider to come see the patient. Once the provider finishes with their they make a plan, and then they can kind of go grab the RN, the behavioral health, the diabetes educator, clinical pharmacy. This process leads to possible long wait times, long visits, poor preparation for the visits, less effective follow-up for the visits, and it's mostly provider-driven. In the medical home model, prior to the visits, the TA, the RN, the PCC have already contacted the patient for follow-up for chronic diseases or for preventative medicine reminders. The MA and the provider have their 20 minutes in the morning to scrub the patients in their huddle, and the plan for the visit is made collaboratively, and the patient may see the RN, the PCC, the behavioral health provider prior to even seeing their provider. During the visits, the MA controls the plan for the visit. There are warm handoffs available for behavioral health if anything arises during the visit. The clinical pharmacist is also available for complicated medication questions while the patient is in the room. And then after the visits, the provider makes a plan for the team to continue contacting the patient to help them with his or her care plan. The medical home model is more patient-centered. There's a better preparation for the visits. It maximizes the care in the clinic, facilitates better follow-up, and the care is driven by the team, not just the provider.
Okay. So I'm going to review a little bit about an example of a patient-centered same-day visit, a pretty classic example of how we utilize the team. So in the center there you can see the patient, a 26-year-old female calls in wanting a same-day appointment with her PA because she's having some abnormal vaginal discharge. The PA doesn't have any open visits, but the other provider on our team hears the call come in to the PCC and glances at his schedule and notices that he has an opening at 3:20, and actually knows the patient because he has seen her one other time in a similar situation. The patient is then able to get a same-day appointment. The TA then remembers that this patient is on her tracking list and is due for a pap smear, so she lets the provider and the MA know so the MA can prep the pelvic tray appropriately. While the patient is in clinic, she asks for a refill on her levothyroxine. The provider glances at her problem list and sees her PCP's plan to get the TSH at the next time she's in clinic, so he orders a lab and gets her refill ordered as well. He also notices that she's not on any birth control and has the RN come in after the visit to offer the patient some birth control education. In the end, the patient chooses to use the pill, and the provider sends the order for birth control to the pharmacy for the patient. So as you can see, this is a good example of same-day appointment where we increase our access, we maximize care in the clinic for the patient, and utilize the team for all the education for the patient.
Okay, this is Lydia again. Bear with me, this is a wordy slide, but this is one of our more classic flows of a more complicated visit with a diabetic and how we would utilize the team, which is, with our diabetic patients, I think one place that we do it really well. So we're going to address an uncontrolled diabetic using the resources of medical home model. Armando is a 56-year-old male with uncontrolled diabetes who has an appointment today. At his last visit 3 months ago, his A1C was 9.8. He had not taken any steps to modify his lifestyle and was taking the big pill when he felt like his sugar was high. Not bringing in his medication, but judging by his med list, I had to assume that his big pill was metformin. He's not able to reliably confirm or deny he's taking any other meds on his med list. In our previous model, I would have had about 2 to 3 minutes after our history and physical exam to tell Armando that he needs to bring in his meds next time. He should exercise and watch his carbs and sugars. We have diabetic education classes that he can sign up for on his way out, and he's supposed to take his metformin BID and not PRN. Come back and see me in 3 months. In our medical home model, and we're up in the top left corner here, in our medical home model at Armando's last visit, I was able to easily identify him as a patient that would benefit from more involved help from our team. Before I left, I introduced him to our behavioral health provider. Behavioral health was able to do a quick warm handoff and engage the patient regarding a patient-centered plan about what changes the patient thinks he can make in his lifestyle, and then they make a plan for close follow-up to continue to work on this together. While behavioral health is in talking to the patient, I discuss his care with our patient care coordinator, who prints out a few picture-based informational handouts for the patient and meets with him briefly after the behavioral health provider to discuss our different diabetic education class options and help the patient sign up for one. She's also able to schedule an appointment with clinical pharmacy to see the patient in the next 1 to 2 weeks to do a med rec and consider optimizing his diabetic medication coverage. After the patient care coordinator leaves the room, she makes a note on the patient's chart, which helps her track the patient and make sure he attended a class and his CPS appointment. After the patient leaves, I'm finishing his chart, I delineate a plan for the RN to call the patient in a month and follow up on the overarching plan for the patient to assess what pieces have fallen through the cracks. She's also able to speak with the patient about any changes that have been made to his medications or lifestyle and offer encouragement, education, or another follow-up appointment. Now moving over to the top right corner prior to the visit. The morning of the visit, our team huddled and we identified that Armando has engaged with behavioral health 2 times since his last visit, but was unable to make it to any of his clinical pharmacy appointments and therefore needs a full medication reconciliation today. The patient care coordinator will check the CPS appointment, the clinical pharmacy schedule to see if they have any openings in their schedule prior or at the time of the appointment with the PCP. If they do, it will be noted so that pharmacy can see the patient prior to the primary care provider today. The patient care coordinator calls the patient to let him know of the plan and to remind him to bring in all of his medications for the provider to review. If he's checking his glucose on a glucometer, she'll remind him to bring this too. The team assistant notes that he's not insured, but identifies him as a patient that may qualify for Medicaid coverage, so also makes the plan to talk with him before he leaves clinic. We also ask behavioral health if she would like to check in with the patient briefly and add this to his schedule. The MA and I scrub the chart to figure out which back office labs or vaccines are due today. Throughout this discussion, it's the MA's job to be noting who will be involved with the visit today and the expected flow. Moving on to the visit during the office visit, bottom left. When Armando arrives, the MA knows that he's due for an A1C, a urine microalbumin, and a lipid panel from our discussions during the huddle. She also identifies him as needing a Pneumovax vaccine. She gets him roomed, collects his back office labs, and asks him if he brought his meds and gets them on the counter for the provider. She also does a quick medication reconciliation with the patient. She also performs a diabetic foot exam and documents the results in the chart. She lets clinical pharmacy know that they can go see the patient because time permits, and she's able to give him his immunization. Once clinical pharmacy is done with the patient, they let the MA know, who calls the behavioral health provider and lets her know she can see the patient briefly. At the same time, the PCP, I can briefly check in with clinical pharmacy to review their visit and any med change recommendations they made. I'm able to see the patient now after he's already been touched by 2 other professionals in the clinic, as well as received a call to help him bring in his meds and maximize his time in clinic. I work with the patient on any other issues that have come up, encourage any changes that he's working on, and support recommendations made by clinical pharmacy in terms of med changes. This is a way to maximize the patient's effective time in clinic and minimize his actual time in clinic. When I go to enter the room, the lab results are waiting for me. His A1C is much better now at 7.5. Now I have 20 minutes with the patient to discuss his goals that are already set and congratulate him on his successes, focus on his med adjustment, and reinforce these changes. Before the patient leaves, the patient care coordinator pops into the room again to quickly see if there's any other classes that the patient would like to schedule, and our team assistant checks in with him about his insurance and schedules an appointment with one of our insurance specialists. The patient is done with the team, and he goes to lab across the hall and then out to the pharmacy. And then lastly, after the visit, I finish my note with a plan for the following 3 months, and if this involves any further tracking, I can forward this back to my team. If his A1C had not been controlled, a further option would be to start insulin with team education support and refer him to clinical pharmacy to help with more frequent visits for titration of his doses. This case demonstrates a full team approach to care. Everyone's taking responsibility for their portion of care and feels pride in the patient's successes. All right.
Okay, so I'm just going to briefly talk about the benefits. So a lot of benefits to the medical home model. One of the most important benefits is to the patients. They have more comprehensive care with all the resources that we have in the clinic and easier access to their team. So they have direct phone numbers for referrals and appointments within our team. And our team gets to know the patients better, their barriers and how to help them. And at certain team meetings, we can discuss the patients and brainstorm better ways to optimize their care and their experience. So this results in engaged, empowered, happier, and more satisfied patients. The Institute for Healthcare Improvement findings on morbidity and mortality related to patient-centered care shows that patients have improved health status, more improved communication, and better provider-patient interactions. The model also reduces patient symptom burden, helps patients comply with treatment regimens, and reduces the chance of misdiagnosis due to poor communication. Here's a picture of our great staff. And the benefits to the staff, so we take pride in our team and of the patients that we all carry together. We have great close interactions with our patients. It's a smaller group of patients to manage. And we get to, as said previously, we work at the top of our license. So where I was working before, there was different allocation of jobs, but here I'm not doing the admin work as much as before because I have a great team to help me with that. And another thing that's important is that there's this less of a hierarchical feel that sometimes medicine can have, and we have this extra support and overall helps prevent provider burnout.
So one of the biggest things with healthcare is rising costs. So one of the biggest benefits as well is helping reduce healthcare costs as we use different staff to kind of achieve the same goals. We also help improve patients' health outcomes by population-based because a lot of the team members can actively outreach our patients before they need something or to remind them that they need certain chronic disease management things that we don't do in clinic at all times. If patients also feel like they can reach us or can get to clinic a lot better and we provide good care here, they will tend to call us first and when they're having kind of any acute illness, and we can kind of help reduce ED visits or emergency care visits. And then we're able to use our resources better, which then reduces costs as well. The American College of Physicians estimates the widespread implementation of a medical home model would lead to a $175 billion reduction in U.S. healthcare expenditures over a 10-year period. And then something that we're still working on and we're doing a kind of continuing to go is the critical goal of healthcare is affecting behavior change by creating continuous healing relationships between the patient and his or her family and the healthcare team. Like I said, we're still working on this, but kind of well on our way.
And here's so the whole collage of our team having fun together, which we tend to have as well. But thank you for your time, and we're happy to take any questions.
Excellent. Thank you all so much for a really outstanding presentation and sharing the great work that you all are doing there at Virginia Garcia, and giving us a little bit of a glimpse into your lives as well and your team, and nice to see the fun that you all have together as well. So at the moment I don't see any questions, but we'll certainly encourage folks to use the chat box to submit any questions, and unless Chris or Sadie, if either of you are seeing something that has come in. In the meantime, I do have a question just to follow up on the case study that you presented with the patient Armando with the diabetic patient and the issues there in getting the A1C levels reduced. I was wondering if you had any data that you've been able to track over time since you've moved to the team-based model, where you've seen a shift in the percentage of diabetic patients at the clinic, and in terms of those who have the A1C level under control per the UDS standard. So have you seen a shift there over time that correlates to the shift to the team-based model?
I'm actually not aware of data that we have that specific to when we implemented team-based care and how our A1Cs have improved. I do know that the behavioral health team and the clinical pharmacy team do their own reporting, and we do every year cycles on how well the patients that we are managing have reduced their A1C, and I can tell you that the latest numbers for pharmacy are about close to almost a full % in A1C reduction for our patients that we work with, and our behavioral health team is about at 0.5% right now of A1C reduction. Keep in mind, these patients that we work with are usually the most complex
right.
and have had years of non-adherence to medication, so moving them is pretty difficult.
Right, absolutely. So seeing a 1% reduction and a 0.5% is significant. That's great.
Yeah, I would second Sam. I don't know, probably somebody in the clinic has some type of data that can look back as far as 2009, but it's not something that's presented to us on a regular basis on how we've done just based on team-based care. We do get our numbers via our panel reports on a monthly basis, and despite how nice that whole case study sounds, that's something that happens, but we are probably, like everybody, still working hard on trying to get our diabetics under control. So it's not, it's not all roses over here with diabetes.
Sure, sure. Well, yeah, thank you for that. I'm sure everyone that's listening can certainly relate to that. So another question that I have, obviously, of course, the focus of the presentation today was really to be about the work that you all do in clinic and, as part of that team-based care model, though I'm wondering a bit about, since Oregon, of course, you all have, you have the CCOs that have been developed there, and it's my understanding that Virginia Garcia is involved in, I think, at least one or perhaps two CCOs in the counties that you serve. Is there any interaction within that model that relates to the services that you provide, or is it really just something that's distinct from what you do in clinic in your team-based model?
So in regards to our providers, a lot of their interactions aren't normally with the CCOs, but the clinical pharmacists and the behavioral health providers do sometimes go to meetings with the CCOs, or in particular, there is a big collaborative with clinical pharmacy and Care Oregon. And they provide us more metrics and kind of help us with some non-adherence data for patients so that we can outreach them. And then obviously some sharing of ideas in between different organizations in the area as well. And I know for the behavioral health team, there's also a lot of work in Yamaha County on mental health because since they're a little more rural, they have less access to things, so they kind of help them out for those behavioral health providers in that area.
Okay, great. So it does look like I'm seeing a couple of questions that have come in, and so one here is if you have a cap of the provider panel, and if so, what's the number of patients?
We do a full-time provider panel. The last number I heard was 1,200 patients, cap at 1,200 patients for full-time. Do you know?
1,200, 1,500, I forget what it is. 1,200
Yeah, Dana is full-time right now, but we also have a lot of our providers here in Hillsborough do family medicine OB, and so their cap changes depending on how much OB care they're doing and call and such. But I was full-time for a while, and I believe it was 1,200, but that was a few years back, so I don't know if we're probably somewhere between 1,200 and 1,500.
Okay, great, thank you. And a couple others here. A question around funding. So how did you get funded to have all of these team members?
So I don't know if I have since I'm not directly involved in the funding for the clinic, I don't know if I have a direct answer. Do you, Sam, have any more?
So for clinical pharmacy, we kind of do a lot more quality, but we do have some funding through Care Oregon with certain metrics for our complex patients who are using the healthcare system a lot. So there's reports that they give us, and we outreach these patients and have more hands-on touches with them, so we get reimbursed for those, which helps for clinical pharmacy services. And I believe for behavioral health, there's a partnership that we have with LifeWorks here. That's kind of how we get behavioral health services. But other than that, I know our foundation team is always constantly writing grants.
Yeah, so there's funding through our federal funding, and then grant funding and donation funding. And like I had said at the outset of this, Care Oregon did find money to do some funding to start the whole process. And now I know we're getting funding through meeting tier levels at the federal level as a federally qualified health center, and so I think that's how we maintain that funding. That's probably about as much information as I can give into that, though.
Great, thank you for that. And then just one last question here, and I know we're just now coming up on time. So how much admin time do the providers get?
Full-time provider gets 4 hours a week. Yeah.
And it's usually spread throughout each day.
Great. Well, I again appreciate you all making the time this afternoon to present on the great work that's happening at Virginia Garcia, and thanks to everyone for joining the webinar. Please keep in mind that we'll have our next webinar in this series will be in June. We're skipping the month of May since we will be having our annual Spring Primary Care Conference in Portland. So if you don't know about that already, please check out our website at nwrpca.org, and hopefully some of you will be able to attend that. With that, again, I'll thank our team from Virginia Garcia for presenting, and wish you all a great day and a great rest of the week. Thanks so much, everyone.